This is a refresher on the model of care and how informal caregivers can use the toolkit from the model of care with participants who have Alzheimer's disease or dementia. Objectives for this lesson are to examine the problem, poor function in nursing home placement, and to review the solution, use of the model of care, to describe Alzheimer's disease and dementia and the desired outcomes for people with these conditions, to examine effective informal caregiver engagement strategies, and to report on why and how the model of care toolkit was modified for use by informal caregivers of participants with Alzheimer's disease and dementia, and to discuss how my choice clinicians will utilize the model of care and the modified toolkit with informal caregivers of participants with Alzheimer's disease and dementia. So here's the problem and why the model of care is needed. As you know, 42% of older adults report a problem with function or disability, and the number of disabled are increasing due to obesity and chronic conditions. So this leads to an inability to carry out ADLs and IADLs like bathing, dressing, eating, walking, and shopping. And disability can lead to falls, poor quality of life, and nursing home placement. There's also a problem with polypharmacy, which is the simultaneous use of multiple drugs for one or more conditions and the use of 4 or more medications. It's very common in the elderly, with 40% of older adults having polypharmacy and 21% of disabled people having polypharmacy. In the My Choice program, 95% of the participants have polypharmacy. On average, they take 7 medications with a range of 0 to 48 medications. And on average, 5 different doctors prescribe the medications. Multiple medications can cause harm, increase falls, delirium, dehydration, constipation, and bleeding. My Choice supports coordinators list medications, and some participants receive help with medication setup, but few participants in the past received a medication review, and medications to avoid in the elderly are not avoided. So here's the solution. We're going to do a review of the model of care and the toolkit use in the My Choice program. As you know, we started with the capable intervention over 10 years ago, which consisted of 6 OT visits and 4 RN visits to address pain, mood, medication, strength and balance, and primary care physician communication. And in some instances, pharmacists reviewed the medication list. This was only done in very few waiver sites. But now we're doing the My Capable intervention, which was adapted for My Choice, where we added OT to My Choice, a few additional home visits tailored to need. The RNs were taught to use the Hippocrates app to review the medications, and we found improved ADLs and IADLs, reduced falls and hospitalizations, and 95% of participants was satisfied with My Capable and felt that they could have this type of help to stay at home. And then we modified My Capable name to call it the Model of Care for My Choice, and have since, in the past 2 years, implemented the Model of Care statewide in all waiver sites. So let's review the Model of Care core elements. It's participant-driven. You ask and listen to their desires and check for their readiness and consult but not treat them. It's culturally relevant, understanding where the participant is coming from. You do problem solving to help to name an issue and find ways to solve problems. There's also significant customization, which is tailored to the person and their environment. We use active engagement to help the participant and informal caregiver learn new strategies, and it's interprofessional with the RN, OT, and social worker. In essence, we focus on the person-environment fit, tailored to whatever home setting they're in, and it's also preventative to improve function. Those are the core elements of the model of care. The model of care has 4 phases. Assessment, where you look at the participant, their situation and home environment, and check their readiness to change. It's also use of the person-centered service plan, where you problem solve, collaborate on development of the plan and expected outcomes and goals, and then enact the plan. And based on their need and desires, it's flexible and changes as needed or desired. All elements of the model of care do not need to be provided unless they're desired and needed by the participant. A key element is enacting strategies to improve the life of the participant. In essence, the supports coordinators and OT role model what to do to enact strategies with the participant and their informal caregiver. In addition, we evaluate strategies and modify them as needed or select new strategies to try. So those are the 4 phases of the model of care: assessment, person-centered service plan, enacting strategies, and evaluating strategies. So let's focus and review the intervention. It uses a focused assessment so that it individualizes care for the participant. It's been used for nursing facility transitions, new admits to My Choice, after a hospitalization or a fall, or when a decline in function occurs. It motivates the participant to improve their function or problems that influence poor function. Sometimes there's an increase of home visits over 1 to 3 months if they're needed. That may include an additional 1 to 4 RN visits plus a medication review. For the OT, it's 1 to 6 home visits, and for the social worker, it's an additional 1 or 2 visits. But not additional visits are not always needed. There's also interdisciplinary coordination to discuss and coordinate the plan, just like the SCs already do. And then we've developed an evidence-based toolkit to use with participants and informal caregivers. It provides information on aging in place for participants. It was modified to assist the informal caregivers when caring for participants with Alzheimer's and disease or dementia, because this occurs commonly in the My Choice program. So here's the focus of the RN care. Preventing falls. We'll do this because 30% of participants in My Choice fall and 10% have a repeated fall. We focus on building strength and balance to prevent falls, and also managing dizziness and memory issues, and managing pain, where over 80% in the My Choice program experience pain. This can significantly impact someone's quality of life. RNs also manage incontinence and also focus on medication review and management, listing the medications taken, assessing interactions using the Beers criteria and via the Hippocrates app, and then modifying the medications with the PCP or a specialist as needed. And then coordinating care among the team. The main focus is to engage the participant and their informal caregiver to select toolkit strategies to support use of the model of care. The focus of care shifts from disease processes to how diseases affect function of the participant. And here's the OT focus of care. If OT services are needed, the OT does a home tour, examining the person-environment fit and observing how the person moves within their environment. They complete an assessment with the following in mind: decreasing falls, like use of railings, grab bars, step or walkway repairs, clutter issues, or proper footwear. They can also focus on improving safe mobility, like transfers from the shower to the chair, tub bench, or chair bed risers, cushions, or bed rails. They can also focus on improving ADL independence, like with bathing, dressing, grooming, hygiene, feeding, rest, and sleep. Or improving IADL independence with meal prep, laundry, phone use, financial management, shopping, taking meds, or social activities. And they can also focus on improving home safety. One of the key elements is obtaining and utilizing devices and home modifications to support a participant's goals. The OT engages the participant and their informal caregiver to select toolkit strategies to support use of the model of care. An OT's holistic view of participants makes them uniquely qualified to assess how daily activities affect participants' health. And here's what the social worker focus of care is. They can conduct a mood assessment if it's needed and manage sadness and stress, or depression, which is a common problem among older adults, but not a normal part of aging. They can also provide brief counseling for sadness, stress, and depression, and identify and obtain community resources. They can address family dynamics and other mental health issues. A social worker can engage the participant and their informal caregiver to select toolkit strategies to support use of the model of care. A key component of social work care is to role model how to use strategies so that the participant can self-manage when the social worker is not there. This is what the table of contents of the toolkit looks like. It's available to all waiver sites to print and use with any participant. There are specific aging and place items, and every item within the toolkit has these outlined topics, like what it is, how do people describe it, what causes it, what they can do about it, some tips that may be helpful, what others can do to help, and what should be reported to the nurse or doctor or discussed with the nurse or doctor, and where to get more information. There are also information sheets, which are evidence-based information from the CDC on how to do a fall prevention checklist, what to expect as you get older, or exercises, both if you're able to ambulate or if you sit in a wheelchair, and healthy food choices. If needed, there's a form called a medication calendar and an OT assessment and home environment tour form. We also have a health booklet which any waiver site can download and print for any waiver participant, which organizes the participant's health information in one place and allows them to take an active role in their health and facilitates communication with healthcare providers. Here are the model of care principles. The first one is person-environment fit. It's focused on how the home environment and where the participant lives is fit for usability to do ADLs and IADLs. The second one is person-centered and self-directed care. It's structured in a way to elicit the participant's desires and needs. The third one is building a collaborative relationship. Intentional building of a trusting environment, trusting relationship with a participant and their caregiver. It's one of the keys to support the model of care. And the fourth item is building self-efficacy of the participant. It's a belief that the participant has their own abilities to face challenges and make choices. These are the 4 principles of the model of care. So what is the person-environment fit? It's a fit between the participant and their environment, like their home, apartment, or condo, and is very important because we focus on it to improve the participant's use of the environment and to support the participant living at home and to improve how the environment supports the participant. Person-centered care is providing care that is respectful of needs and values, cultural traditions, personal preference, family situation, social circumstances, lifestyle, and needs, ensuring the person guides their decisions. Elements include whole person care, coordination and communication, support and empowerment, ready access and autonomy. Principles include respect for preference, physical comfort and emotional support, involvement of friends and family, and access to care. Collaborative relationships are forming relationships based on trust and respect. Trust and adherence to the plan of care to improve when the supports coordinator connects with the participant and their caregiver. A participant must feel that the supports coordinator understands their condition and situation and has their best interest at heart. Supports coordinators should take the time to let the participant know they care for them, and remember, supports coordinators begin building rapport the minute they meet a participant. The supports coordinator engages the participant and their informal caregiver to select toolkit strategies to support use of the model of care. And finally, self-efficacy is the extent or strength of one's core belief in one's own ability to complete tasks and reach goals. High self-efficacy affects motivation in positive and negative ways. People with high self-efficacy are more likely to make efforts to complete a task and to persist longer in those efforts than those with low self-efficacy. Obstacles often stimulate people with high self-efficacy to greater efforts, where people with low self-efficacy will tend towards discouragement and giving up. A person with high self-efficacy will attribute failure to external factors, where a person with low self-efficacy will blame low ability. Low self-efficacy can lead one to believe tasks to be harder than they are, resulting in poor task planning and increased stress. Those with low self-efficacy experience incentives to learn more about an unfamiliar subject, where someone with a high self-efficacy may not prepare as well for a task. Success can raise self-efficacy, while failure can lower self-efficacy. The model of care also includes 4 approaches. The first one is readiness to change, where you assess willingness to use new ways of carrying out daily activities. The second one is motivational interviewing, known as MI, to encourage participants' use of strategies to manage at home. The third one is cognitive behavioral therapy, which is short-term, goal-oriented, focused on how thoughts and feelings impact behavior. And the fourth one is brainstorming, problem solving, and role modeling. Discussion to produce ideas and ways to solve problems. So readiness to change is the extent to which an individual is cognitively inclined to accept, embrace, and adopt a particular plan to purposefully change. Helping participants change behavior is an important role for clinicians. Change is useful for addressing disease prevention and management. Understanding readiness to change, appreciating barriers to change, and helping participants anticipate relapse can improve participant satisfaction and lower clinician frustration during the change process. There are 5 stages of readiness to change: pre-contemplation, contemplation, preparation, action, and maintenance and relapse prevention. Here is the assessment tool used to assess readiness for change. First, think about, does the participant acknowledge deficit areas? If it's yes or no. If no, are they in pre-contemplation? Is everything okay? Or are they just old? Or are they trying to, have been like this for a long time? Or they don't see the point in changing and they're not listening? Or are they in contemplation where a problem exists trying to understand, reading about a diagnosis, or thinking about action changes. And then if it's yes, if they acknowledge deficit areas, does the participant indicate a willingness to try different strategies such as behavioral or environmental changes to help make daily occupations easier? Are they in preparation with intention to take action, willing to listen and ask questions? Or are they already in action and maintenance, active participation? They're ready to modify their behavior and try new ideas and practice and modify and use strategies. So you can see the point system here allows you to get a readiness score, and you learn over time as you use this readiness to change scale quickly how to evaluate which of the 4 stages a participant is in: pre-contemplation, contemplation, preparation, or action and maintenance. And then there's motivational interviewing. It's a person-centered, goal-oriented method of communication to strengthen motivation to change. Pharmacists use it all the time. The principles of MI include expressing empathy, understanding the reality of a person's situation, then developing discrepancies, focusing on personalizing desires, reasons, and ability to change, and rolling with resistance. You don't push for change, order or confront, and you don't provide information prematurely or without permission. And then you support self-efficacy. It helps others to find ways to be successful that will work for them. Identify skills and abilities that will help them make the change. There are 10 elements of MI: a collaborative communication style, focusing on change, eliciting and strengthening intrinsic motivation. It's centered on the person and honors autonomy. It's goal-oriented and specific, and guided by the person's conversation. It uses brief context, learnable skills, observable, measurable skills, and it's very adaptable. The model of care also uses cognitive behavioral therapy, CBT. It's a short-term, goal-oriented psychotherapeutic approach which is founded on the idea that thoughts cause feelings and consequently behavior. Here are the 2 principles. Negative thoughts can block ability to take action. An example is not believing the exercises will help improve strength and balance. And the second principle is negative thoughts can block learning new behaviors. An example of this is not doing exercises to improve balance and sitting in the recliner all the time. There are 4 elements that it combines psychological and behavioral therapy: assessment, reconceptualization, skill acquisition, and application. Social workers are taught CBT and often use it in their care as supports coordinator. There's also brainstorming, which is a spontaneous group discussion to produce ideas and ways of solving problems. It's a technique to solve specific problems, collecting information, stimulating creative thinking, and developing new ideas. It's a relaxed, informal problem-solving method. These ideas lead to new ways of looking at things, and it helps people who are stuck solving problems. There's no criticism of ideas or no judgment. There's also problem solving, which is the process of working through details of a problem to reach a solution. All problems have 2 features: goals and barriers. Goals or problem solving involves setting out to achieve some objective to avoid a situation or event. And barriers or problem solving involves overcoming the barrier that prevents achievement of goals. And then there's role modeling, a person who serves as an example for others, demonstrating a behavior or role for another person to copy. We role model how to problem solve and brainstorm a health need, like how to use the toolkit to identify strategies that may be effective for a specific problem or issue. Supports coordinators are not in the home all of the time, so the participant and informal caregiver need to understand how to problem solve, and brainstorm day to day on their own. The model of care also has 4 techniques. Communication, which is a two-way process or exchange of thoughts, feelings, or ideas towards a mutual goal. Collaboration, which is the process of 2 or more people working together to realize and achieve something successful. And reflection, which is serious thought or consideration. And then interdisciplinary coordination, where all the team members, including the participant and informal caregiver, work together to help attain the participant's desires or needs. Communication is a process by which information is exchanged between individuals through a common system of symbols, signs, or behavior. Communication can be perceived as a two-way process in which there's an exchange and progression of thoughts, feelings, or ideas towards a mutually accepted goal or direction. Major part of human communication is body language, voice, and words. 55% is by body language, like posture, gestures, or eye contact. 38% is by tone of voice, and 7% is by the words used. There's also collaboration, which is the process of 2 or more people working together to realize or achieve something successfully. It requires leadership. Teams that work collaboratively can obtain greater resources, recognition, and reward when facing competition for finite resources. It encourages introspection of behavior and communication among the team to increase the success of the team as engaged in problem solving. There's also reflection, which is serious thought or consideration, thinking about an experience, and examination of personal thoughts and actions. It's a very useful technique. And interdisciplinary coordination, which is the awareness of personal biases towards other disciplines, skills to communicate with others effectively, and knowledge of what other disciplines do. And encounters facilitated for effectiveness and desire to work as a team. It improves participant care and safety, access to coordination of health services, and communication. It reduces mortality rates, clinical errors, cost, and tension and conflict among clinicians. And you gain familiarity with diverse situations. So that's a wrap-up and a refresher on the model of care. And now we're just going to talk a little bit about dementia and Alzheimer's disease and what it is. Here are the 8 types of dementia, with Alzheimer's disease being the most common form of dementia. There are also different stages of dementia. One is the pre-symptomatic stage, where the physical conditions connected to dementia exist in the body before the symptoms are even evident. And then there's prodromal stage, where mild cognitive impairment occurs. It's between the normal age-related memory loss and dementia. Persistent memory problems often lead to Alzheimer's disease. And then there are 3 stages of Alzheimer's disease. Mild, which is stage 1, where you get loss of energy and spontaneity, though no one notices anything unusual, and you exhibit minor memory loss and mood swings. Speech and understanding become slower, and you lose your train of thought mid-sentence. And then there's moderate, which is stage 2, where a person with Alzheimer's eventually begins to be disabled. They're able to recall distant past. Recent events become difficult to remember, and it affects ability to comprehend location, day, and time. Caregivers must give clear instructions and repeat things often. And then there's severe Alzheimer's disease, which is stage 3. It's the final stage. People become more and more unresponsive. Memory becomes so poor that no one is recognizable, and they lose bowel and bladder control, and they need constant care. So those are the 5 stages of dementia. So the desired outcome for people with dementia include attaining and maintaining the highest level of function, decreasing the severity and frequency of neuropsychiatric symptoms, delaying institutionalization, and promoting caregiver and person-centered decision-making, reducing caregiver stress and burden, and enhancing the caregiver knowledge and comfort with the dementia care. Use of the model of care and the toolkit can help attain all 6 of these desired outcomes for people with dementia and Alzheimer's disease. So let's talk about how to engage an informal caregiver and what is the role of the informal caregiver when we're doing the model of care. The problem with the model of care is it was designed to be used by participants. During implementation in My Choice waiver program over the last few years, many caregivers stated the participants with dementia and Alzheimer's disease were unable to use the model of care as they could not follow instructions or were unable to communicate. So our solution to this was engaging the informal caregivers to assist with providing the model of care to participants. Caregivers need to be prepared for their caregiving role by learning information and caregiving strategies. The caregiving role is constantly evolving throughout the stages of illness with dementia. With a progressive disease like Alzheimer's, strategies that work one day often don't have the same effect the next. So caregivers need to continually educate themselves on strategies to work in their daily routine. Here are some effective caregiver engagement strategies. Use of a short and succinct evidence-based intervention, like when My Choice uses the model of care. The second effective strategy is use of high-quality clinicians. And in My Choice, there's use of RNs, social workers, and OTs as needed. And the third effective engagement strategy is use of supporting materials that are tailored to participants' needs. For this, My Choice can use the toolkit. The toolkit can prepare an informal caregiver for their role by providing information and caregiving strategies. The toolkit can help activate an informal caregiver to care for an older or disabled person or someone with Alzheimer's disease or dementia. So how did we modify the toolkit? We followed these steps to modify the toolkit. In step 1, 5 expert clinicians in care of those with dementia or Alzheimer's disease included information in the toolkit from the National Institute on Aging Alzheimer's Disease Education and Referral Center. In step 2, we asked 5 experienced My Choice informal caregivers of participants with Alzheimer's disease or dementia from Region 7 Area Agency on Aging to review the toolkit. Their average age was 46.2 years. 80% were white and 1 was African American. 3 had an associate degree and 2 had a high school diploma. 3 of them were daughters. 1 was a daughter-in-law and 1 was a grandson. They recommended 28 additions and 12 areas to be made clear from what the experts provided in step 1. After use of the toolkit, these 5 caregivers made the following statement. These toolkits should be given to all caregivers. I did not know there were 5 stages of Alzheimer's disease. The toolkit would be helpful to caregivers. This is a hard disease to work with and requires as much information as possible. The part, what can a caregiver do to cope, was new and very helpful. And finally, this isn't something I would have thought of being an issue. Good ideas on what caregivers can do. So the toolkit can be printed and used with participants and informal caregivers when using the model of care in the My Choice program. So here's what we added to the modified toolkit. Sections on Alzheimer's disease or dementia that in regard to bathing, grooming, dressing, and toileting, fall prevention, physical activity, sexual health, pain, sleep disruption, medication management, and home safety. because there are specific issues in regard to dementia and Alzheimer's disease that needed to be included. New information for informal caregivers when caring for a person with Alzheimer's disease also were added, like exactly what is Alzheimer's disease and what physical function can be addressed in that type of participant, and specific sections on agitation and aggression, hallucinations, delusions and paranoia, rummaging and wandering, which are all significant problems of people with Alzheimer's disease. So how do you use the model of care and the toolkit? Exactly what do supports coordinators do? Here's a procedure on how to use the model of care. Step 1. The supports coordinator determines if the model of care is needed and appropriate for a participant to have a better fit in their environment. Participants with Alzheimer's disease or dementia often need behavior modification, specifically aggression and agitation management. And NIFTY and post-hospital and nursing home stays are likely to benefit from OT or increased RN and social work visits. Step 2. If you determine OT would be beneficial, order and notify the OT to start care and use your waiver site process. If you determine if additional RN or social work visits would be beneficial, provide the care as per your waiver site process. Participants with Alzheimer's disease or dementia often need improved hygiene or DME to reduce fall risk. Then step 3 in the procedure, supports coordinators engage the participant and informal caregiver in use of the model of care, designing the person-centered service plan focused on the participant's desires and needs, and selecting strategies from the toolkit to improve the fit between the participant and the environment. Step 4, the supports coordinators coordinate the interdisciplinary team caring for their participant, and step 5, document in electronic health record. So this is the procedure on how to use the model of care, and we provide a pocket card with specific information on each of these steps, which you can print and carry around with you, or carry electronically on your laptop. There's also a procedure how to use the toolkit. Step 1, you print the toolkit and bring it to the home on your next home visit. The objective is to have the toolkit available for use when it's needed. Step 2, you explain the purpose of the toolkit to your participant and caregiver. The objective is to select strategies to self-manage common problems. Step 3, you review the toolkit table of contents. The participant and caregiver need to know what's in the toolkit. And then in step 4, you ask the participant and caregiver what topic they need help with. You review the toolkit topic with the participant and role model how to select strategies to resolve a problem or issue. You repeat these 2 steps until the participant and caregiver can use the toolkit independently. And in step 5, the supports coordinator collaborates with the participant and caregiver to select 4 to 6 strategies to use and list them on the person-centered service plan. The participant and caregiver select the strategies to try and use. And in step 6, on future home visits or calls, the supports coordinator evaluates the effectiveness of strategies at resolving problems and issues. The objectives are if the strategies work, you continue using them until the problem's resolved, or if the strategies did not work, you select different strategies. So this is the simple procedure on how to use the toolkit to support the model of care. And then you do your documentation of all of these items as usual in your electronic health record. Please note the OT home environment assessment is a paper copy, and the participant OT assessment is a paper copy for those who don't use SIM. But if you're using SIM, it's electronically been installed in the record already. The person-centered service plan is exactly as in the My Choice program, and then the progress notes are exactly the same. It is helpful if you document readiness to change scores in the progress note because they can change over time. So let's talk about a case study, Mrs. S. She's an 84-year-old female who lives in a house with her husband who's 85 and in hospice with lung cancer. She has Alzheimer's disease at stage 2, diabetes, coronary artery disease, chronic pain, and hypertension. Her informal caregiver is a grandson, and she's been in my choice for over 8 years. On assessment, in regard to ADLs, she often refused to bathe, and when she bathes, she's not getting clean. She has difficulty with transferring and ambulating, and she's unable to do any IADLs. Her pain is constant from arthritis, and her nutrition is poor as she does not follow any diet, and she falls 4 or 5 times a year. And in regard to her behavior, she has agitation, aggression, paranoia, and rummaging. Her goals are to improve her bathing, transferring, ambulating, and food intake, reduce her falls, agitation, and aggression. On her person-centered service plan, she and her informal caregiver selected improving her bathing and hygiene, transfer and ambulation, assisted devices for fall prevention, improving her food choices, and managing her behaviors to reduce the agitation and aggression. To improve her hygiene, the caregiver selected these strategies to try from the toolkit. Preparing the shower in advance, turning on soft music, and informing her it's time to shower now. Placing a towel over her lap and shoulders to make her feel covered, and giving her a washcloth to hold, and distracting her by discussing her grandchildren. And she got her dressed immediately after the shower, and washed her hair while sitting in a chair over the sink rather than in the shower. The outcomes were that it was easier to do a shower and hygiene improved. Their caregiver felt 4 of the 6 strategies were effective and continued them. To improve transfers and ambulation and prevent falls, the caregivers selected these strategies to try from the toolkit from the section on fall prevention, transferring, and ambulation. Decreasing clutter, arranging things in the home so they're easier to get around, use of non-skid low-heel shoes, all the others were removed from the closet, and then installing the grab bar by the shower, which cost about $100, installing non-slip grips at home by the side entrance so she could feel secure when entering and exiting, and obtaining a reacher for $25.42. The outcomes from all of this care was all strategies were effective, and she had no falls over 6 months, and the shower, transfer, and ambulation near the door became easier. For this part of the care plan, an OT was used, so you can see there was quite a significant improvement in the participant's function. In regard to food choices, the RN helped the caregiver do these selected strategies. They used a type 2 diabetic diet, had healthy food choices for meals and snacks, and worked to meet the diabetic needs. And they didn't shop for junk food and removed it all from the home. The outcome was the blood sugar levels were within normal limits, and the participant was eating less junk food and feeling healthier and had more energy. And to manage the agitation and aggression, the social worker took these actions with the caregivers, selecting these strategies from the toolkit. They watched for triggers and eliminated triggers that were identified, used a reassuring, speaking calm voice, kept a routine for shower and meals, kept the loved objects and pictures around the house to be comfortable, used soothing music during the shower, and reduced noise and clutter. The outcome for the participant was agitation and aggression were reduced, and all strategies were effective and continued. And regarding satisfaction, the caregiver felt the toolkit was very helpful. Not all strategies worked, but many did. And here are 2 comments from this caregiver. The extra home visits were helpful, and the toolkit was practical. The information was helpful, and I keep rereading the toolkit. Overall, the informal caregiver was very satisfied with the toolkit and the model of care. In summary, regarding this case study, the model of care was utilized to design a person-centered, self-directed plan of care. It was interdisciplinary with all three clinician types used. The caregiver was engaged in selected strategies to try. Care was focused on participants' needs and desires. The caregiver helped implement the model of care using the toolkit. Care was effective and participant outcomes included improved and maintained function, improved behaviors, hygiene and nutrition, and the participant was able to remain in the community with the support of the caregiver. So this is an example of a case study using the model of care and the toolkit in someone with Alzheimer's disease. So what are our next steps? Our team at Grand Valley State University, myself, Sandra Spoelstra, and Monica Schuler, the project manager, are going to pilot test use of the model of care in the toolkit with 60 participants with Alzheimer's disease or dementia and their informal caregivers. A supervisor at your waiver site will identify participants and caregivers and notify the supports coordinators. We'll be mailing the toolkit to the participant's home. The supports coordinator may use any component of the model of care. Just use medication review or have a couple extra OT home visits, or if needed, only additional RN visits or social work visits. And the toolkit will be used with the participant and the caregiver. Also, other participants who are not in the pilot study who need or desire care, the model of care, may use any component of the model of care and toolkit that is helpful, following the procedures outlined in this lesson. Other informal caregivers or participant with Alzheimer's disease or dementia may use the model of care and toolkit and follow the procedures outlined in this lesson. You just simply need to print the toolkit and use it on your next home visit. If you have any questions regarding any of this information, please email myself or Monica Schuler, the project manager. Thank you so much, and please remember to print your continuing education certificate.